Good afternoon and welcome. My name is Kirsten Jensen, and I am the Director of the Division of Benefits and Coverage at CMS. I am joined today by several of my colleagues, including Sheree Gaskins, Melissa Musato, Marlena Thieler, and Ryan Tisdale. Thank you for participating today. As you are aware, the Centers for Medicare and Medicaid Services has scheduled 4 listening sessions centered on non-emergency medical transportation, or NEMT. These listening sessions have been set up so that CMS can gather your ideas on how we can improve non-emergency medical transportation services for Medicaid beneficiaries, with an emphasis on improvements to program integrity. CMS will not be making any presentations today or answering any questions, nor will our facilitation partner, MITRE. The purpose of these sessions is to hear from you, and we encourage you to share your ideas and experiences with us. We will review all the input we get in our series of listening sessions and consider it when making updates to federal policy and operations. I want to emphasize here that we are discussing NEMT, not non-emergency transportation as authorized through 1915 C waivers. So please limit your discussion to non-emergency medical transportation. Under Section 209B3 of the Consolidated Appropriations Act 2021, Division CC, Title II, CMS was directed to convene stakeholder engagement meetings to facilitate discussion on shared learning about the leading practices for improving Medicaid program integrity within NEMT services. CMS is very interested in your input on identifying the ongoing challenges to Medicaid program integrity, as well as the leading practices to address these challenges. MITRE is facilitating these listening sessions on behalf of CMS. MITRE operates the Health Federally Funded Research and Development Center for CMS. I would now like to hand the session over to Jeff Goldman from MITRE, who is facilitating today's listening session.
Thank you, Kirsten. I'm Jeff Goldman with MITRE, and I too would like to welcome everyone that has joined today's session. The purpose of today's session is to gather your input related to non-emergency medical transportation, or NEMT, coordination topics, such as brokers, MCO community transportation, and paratransit services. As Kirsten mentioned, there will not be any presentations by CMS or MITRE, nor will there be any question and answer period during today's session. We very much want to hear your ideas on how CMS can make improvements to the NEMT program through federal policy or operational changes. Before we begin, we have a few housekeeping notes. First, please be aware that this meeting is being recorded for note-taking purposes. By remaining in this public meeting, you are consenting to being recorded. All chat comments will also be captured. For any press that have joined today's call, we kindly ask that you please remember to communicate with CMS through cms.gov/newsroom. We also ask any members of the press to please not use the chat function in today's call to solicit input for other work. As a reminder, if you have any technical questions or difficulties, please reach out directly to Jay Elmore with Moderated Services, either via the Zoom chat or via email at j.elmore@cms.hhs.gov. Somebody will put that in the chat. Also, all participants will be muted throughout the listening session until called on by the moderator, Jay Elmore. Please note that once the moderator calls on you and announces that you are unmuted, you may also have to unmute yourself. You can provide input on NEMT leading practices and challenges in 2 ways. First, you can raise your hand, or second, you can use the chat feature. To verbally provide comments in this listening session, please use the raise hand feature. It is on the menu at the bottom of your Zoom window where you will see a raise hand icon. Click raise hand, you will be placed in the queue, And when it's your turn to speak, your name will be called and it will be announced that you are unmuted by the moderator. Again, you may have to unmute yourself on your end as well in order to speak and be heard. Today's session is broken into 5 sections. The first is for general comments on today's topic, NEMT coordination topics, brokers, MCOs, community transportation, and paratransit services. That section will be followed as necessary by 4 subtopics. We will stay on the general topic until that queue is completely emptied, at which time we will move to the subtopics as remaining time allows. You're encouraged to raise your virtual hand and offer comment or responses to comments in any or all of the sections. You may also use the chat function to offer your input. We will not be using the question and answer feature for today's call. Please provide any written feedback you have to the chat function. Due to the large volume of participants in today's session, we ask that you keep your comments to 2 minutes or less. We would like to prioritize the open lines for new comments. So we encourage you to share your support for other participants' comments by using the chat feature. Commenters will be selected in the order by which hands were raised. We will try to get through all participants in the allotted time, so please keep your responses concise and unique. We may decide to ask for specific comments on one of the subtopics if we feel we have not heard anything related to that subtopic. Your participation in this listening session is voluntary. There will be no individual benefit from your participation, nor will there be any negative effects if you decide you do not want to participate. We would like to hear your honest input about the topics. There are no right or wrong responses. We encourage you to speak openly and honestly. You can choose not to respond to a specific topic or subtopic. You can also end your participation in the discussion at any time. We have allotted up to 75 minutes for the entire discussion. So moving into the discussion, today's session again is focused on NEMT coordination topics, brokers, MCO community, transportation, and paratransit services. A reminder that we ask participants to keep comments under 2 minutes when you are called, and you are called on to allow for as many individuals to be able to speak as possible. We will now open the session for discussion and comments on today's topic, and including today's subtopics: access to services, timely arrival and drop-off, rural issues, tribal issues, coverage of transportation services not provided by Medicaid. So the lines are open now for comments related to the main topic and any of the subtopics.
All right. This is Jay, your moderator. I will start unmuting you now. Our first person in the queue is Dan Reed. You may now unmute.
Hello?
Yes, sir, we can hear you.
Yes, hi, this is Dan Reed with Grove Transit in Mississippi. Coverage for transportation to services not currently provided by Medicaid is a concept whose time has come and needs to be addressed in our current environment. Social determinants of health have a very real and very measurable impact on an individual's overall state of health and on the healthcare industry. Examples of social determinants of health include such things as education, unemployment, job insecurity, food insecurity, early childhood development, and access to affordable health services. Research shows that social determinants can be more important than healthcare or lifestyle choices in influencing health. Some studies suggest that social determinants of health account for between 30 to 55% of health outcomes. In fact, estimates show that the impact from sectors outside of healthcare to overall population health outcomes exceeds the contributions from the healthcare sector. Quite often, the segment of the population currently utilizing non-emergency medical transportation under Medicaid programs also represents a segment of the population most likely to have negative health impacts from social determinants of health. The NEMT transportation currently helps solve just one of the many identified social determinants of health, which is access to affordable health services. By utilizing NEMT to address other critical social determinants, such as food insecurity, A strong argument could be made that the overall cost of the healthcare industry will decrease, since the cost for the NEMT needed to achieve a positive impact on a beneficiary's health will be more than offset, perhaps by multiples, by the reduced overall healthcare costs for the beneficiary. In keeping with the current and evolving need to improve the overall health of a beneficiary, CMS should encourage all states and should encourage Medicaid systems to adapt for the use of NEMT as it relates to social determinants of health. Thank you for your time, and I thank you for these sessions.
All right, next, Casey, you may now unmute.
Thank you. This is Casey Buderi here on behalf of the Medical Transportation Access Coalition. The topics for discussion today represent some of the most significant challenges for NEMT, as well as some key opportunities for the future of the benefit. Brokers are accountable to the state Medicaid agency and Medicaid managed care organizations that contract with them and to the beneficiaries they serve for ensuring appropriate transportation and access, including timely arrival and drop-off. There are numerous challenges to achieving the goal of timeliness, along with other goals of NEMT. One, which we and others have pointed out at these listening sessions, is the challenge of maintaining an adequate provider network. Provider shortages are present both in terms of the overall number of NEMT providers, as well as the number of specialized NEMT providers, such as wheelchair and stretcher vans. And these shortages are especially pronounced in rural areas. MTAC members, along with other stakeholders, have developed strategies to mitigate provider shortages, untimely rides, and other delivery challenges, including electronic scheduling and advanced GPS. But coordination with and leveraging of public transportation and county transit programs where possible is another important tool. While it may be obvious that for beneficiaries in urban and suburban areas, public transportation is often the most appropriate form of transportation, beneficiaries in rural areas, for beneficiaries in rural areas, community transit providers providing regional rural service also play an essential role. And coordination with community transit providers is central and essential in delivering NEMT benefits. And NEMT at the same time is a key component in allowing public and community transportation systems to thrive. I'll turn slightly to talk about one of the subtopics identified for CMS. Identified by CMS for today's session, which was mentioned by the previous commenter as well, coverage of transportation to services not provided by Medicaid. There's a growing recognition among plans that beneficiaries of non-Medicaid programs can benefit from transportation. For example, an MTAC study published in January found that in 2022, nearly 40% of all Medicare Advantage plans are offering transportation. We also note that a growing number of states permit and some encourage NEMT to non-medical sites such as grocery stores and social services. MA plans too are increasingly offering non-medical transportation, demonstrated by that same MTAC study. These policies recognize the reality that food counseling, career training, and other needs must be met if we want people to attain an optimal state of health. And as the evidence on NEMT's ability to improve outcomes and create cost savings grows, the benefit should be expanded for individuals in need within Medicaid and should also extend into Medicare Advantage and other health insurance coverage. I'll stop there. MTAC will also be offering written comments, and we thank you for the opportunity to participate.
All right, the next person that may speak is Scott. Scott, you may unmute.
Thank you so much. My name is Taylor Clockey. I'm representing Scott Ogren with the Community Transportation Association of America. We represent community transportation and private sector providers. We also work closely and directly with MTAC, who just spoke in this NEMT space. Last year, we trained 50,000 drivers in passenger assistance, safety, and sensitivity training, known as PASS. We deliver that training through 23 master trainers and work directly with 11 national NEMT brokers. As CMS examines the NEMT space, we would like to be a part of these important ongoing discussions. Thank you again for a comment to participate.
All right, Kelly, you may unmute.
Hi, thank you for the opportunity. Kelly Mylan with Sunshine Rides in Colorado. We are an NEMT provider. And I'd just like to contribute on the topic of brokers. Our experience has been unfortunately quite negative. We understand the need for governance, accountability, visibility for these programs. In our experience, the concept of a broker is a bit of an outdated or older answer to a modern problem. We would very much like to see clear guidance at the policy level, standards levels, and accountability levels enabled by technology. It's high time that we modernize this industry. And so I just stress that I think brokers are an old answer to a modern problem, and thanks for the opportunity.
All right, Kat, you may unmute.
Hi, good afternoon. My name is Kat. I work for a refugee resettlement agency in Central Ohio. My team coordinates healthcare services for limited and non-English speaking communities. Both the non-emergency medical transportation and the MCO transportation plans have added significant barriers requiring English language to access these services, such as insisting on response of English text messages, to confirm a trip, despite the fact that we have already confirmed and arranged transportation. Members in this community are consistently experiencing interruptions in access to care, and many of the healthcare providers that we have worked with for years are now refusing to see our patients due to the consistency of individuals missing appointments because of this transportation issue. We request that you take into consideration the needs of those that don't speak English as you continue to move forward with plans for these programs.
All right, Peter, you may unmute. Peter, are you there? You may unmute. All right, we're going to come back to you. Clark, you may unmute. Clark Groves, if you're there, you may unmute.
I am, thank you. On the last call we had, someone spoke about the very real disruption to service that happens when a change of brokers occurs within a state Medicaid program. The simple fact of the matter is that broker transitions are a very real part of the broker model. Several recent projects initiated with the NEMT community would help to eliminate the disruption to service that has been a historic landmark of the broker model. Non-emergency medical transportation credentialing exchange could hold provider credentialing information for providers, drivers, and vehicles. Having these credentials within an exchange in an immutable format with their provenance established will make the transition of brokers less disruptive for providers and beneficiaries. In the past, brokers have made the claim that their provider network is proprietary. However, we find this to be specious at best. A state's Medicaid NEMT provider network should be the providence of the state Medicaid agency and not an individual broker. Yes, the broker oversees the management of the contract, but the providers are fulfilling the state's obligation under Medicaid to provide NEMT to those in need. And as such, it is the state that should have full visibility in the network of providers performing this work. In many cases, despite the proprietary claims made by brokers, the NEMT provider network remains, for the most part, intact after a broker transition. NEMT CredX would not prohibit a broker from bringing in its own proprietary network of providers, or to a lesser extent, a large new set of NEMT providers. However, to the extent this is a broker's intention, they should have to disclose this to both the state regulatory body and to the existing provider network. Both groups could then factor this into any decisions made with respect to the broker's bid proposal. In the case of the state Medicaid agency, they can factor in the disruption of service both during and after the transition from introducing a new network of providers. In the case of the NEMT provider network, providers would be able to better gauge their willingness to work with a potential broker, especially if that broker disclosed plans to displace much of the existing network. In reality, the likely outcome is that the supposed proprietary nature of any one broker's NEMT provider network will be shown to be a myth. When that happens, state agencies can then focus their evaluation of RFP responses on the areas of real difference between brokers, rather than the hypothetical claims of a superior NEMT provider network. If in fact a broker does have a distinct and proprietary NEMT provider network, then bid evaluators can focus on the benefits of such a network versus the potential disruption in service and whether there is a real need to replace an existing network of NEMT providers with a proven track record within the state. In summary, my company, Black and White Transportation, is working with NEMT CredX. We're in the process of uploading our credentials for our stakeholders to share with them. We have 4 contracts that will require extensive credentialing. And this solution gives them they have a vested interest in our credentialing process, and we're required on a regular and frequent basis to provide them with this data. It's a time-consuming, cumbersome process for both parties. Once this exchange is in place, we'll be able to allow them to access in real time the credentialing data they require as often as they require it. It'll save substantial man hours for both parties and allow more focus on the recipients of service. Thank you.
Okay, Peter, you may unmute now.
This is Peter Johnke. I'm a transportation advocate with the Vermont Center for Independent Living. And this probably applies more to rural communities than others, but somebody commented about the need for food security. In a rural state like Vermont, oftentimes people are not only far away from their healthcare provider, but they're also far away from essential needs such as grocery stores. The situation came up here where a person under non-emergency medical transportation went to their healthcare provider and then from there to their pharmacy, which was at Walmart. While at Walmart, they picked up just a gallon of milk. They weren't doing any extensive shopping because they didn't have easy access to get that from their residents. And this was not allowed by Medicaid. And such kinds of things are really constricting and really problematic in rural states. So policy-wise, these kinds of restrictions need to be modified. Thank you.
All right, the next speaker will be Luann. You may unmute.
Yes, thank you for this. I'm just a mom from Omaha, Nebraska. My son has Down syndrome, and this is my concern. See, most of these young people get a certain amount of money from the government, and on average, there's $5,000 in there for transportation. The schools have been great getting job experiences and resumes for our young people. The businesses are open to allowing our young people to come in and work. The government from this group of money provides job coaches, money for job coaches to job coach these young people. And then once they're job coached and they've learned the job and they're confident, there's no way to get them to work. My son had a job where he didn't get off at a certain time. It fluctuated between 7 o'clock and 8 o'clock at night. Well, transportation, you get 10 minutes. So we had to, run him. And then the job he has now, he's in the Omaha area, but the job is outside of the bus line. And so again, we have to do all the running. My suggestion, and it has been for many years, is that $5,000, we can only use that if they go to a workshop. So why is the government putting all this money into job coaching and resumes and that when we can't control that 5,000? That my suggestion is that they partner with Uber or Lyft for the higher functioning young people. I'm not saying with wheelchairs and that, but the people, the IDD group of people that can function with Uber and Lyft apps, which my son can, that we could use that 5,000 to pay for that or half of it to go to work, to go to social things, to go to the government, to the grocery store, to go to medical appointments. And that would free up the other transportation, the more specialized transportation for that area, and they would have more time to do that. I have talked to DHHS. They say their goal is to get more young people like this employed. That's their goal for the year. So I'm asking, how do we get them there? Free up that money so that we can make a determination where we can use it. That's all. Thank you.
All right, Shannon, you may unmute. Shannon Thomas, you may unmute. All right, we'll come back to you. Lisa, you may unmute.
Hi, this is Lisa Bacot with the Florida Public Transportation Association. Many individuals in the chat box have referenced a lot of the same issues we have here in Florida in our rural areas. Many of our public transit providers are working with the brokers because there really are no other options, and they're having numerous problems with administrative burdens such as credentialing of the drivers, some operational concerns, reimbursement and billing issues. Also, and someone has mentioned this to the chat box, the hospital releases. People are waiting very long periods of time for that. So we have numerous problems going on in the rural areas. In the urban areas, when Florida switched to a fully brokered model, our ADA paratransit services skyrocketed in all of the urban areas. So we do believe, whether it's being done officially by the brokers telling them to call ADA first, or whether it's happening because the access to service and timely arrival, people just aren't waiting around anymore for the Medicaid providers and they're just calling our transportation services in the urban counties. I'm not sure, but regardless, we are having problems in both rural and urban areas of the state of Florida when the brokers have come in. Thank you.
All right, Shannon, it seems that you're back. Would you like to
Hi.
ask the question? Okay.
I'm so sorry. We've been having all kinds of issues in my neighborhood about power. So if I go out, I apologize in advance. My biggest thing is, and I have actually reported this to our Inspector General, is we only allow one Medicaid provider in our state to do NEMT. And in the last 12 years that they have done it, they have not met the obligations that are contractually set up. So how can an NEMT provider make sure that those services are being guaranteed to each passenger? They need to be to their appointments on time. If they're more than 15 minutes late, they don't get to see the doctor. And sometimes they're completely canceled at all. And this is a major issue in the state of South Carolina. And so with that, I'm just going to go ahead and say thank you so much for allowing me to speak. I apologize if I was late just due to the issues with my power company.
All right. Just another reminder that after I call you all's name, you can go ahead and unmute. Our next speaker will be William. You can now unmute.
Hello, can you hear me? Just confirming.
Yes, sir.
Yes, my name is Will Vanderlinde. I operate several fleets in the state of Virginia. We have been performing NEMT services for brokers that have come in and out of the state for over 12 years. Difficulties we currently experience with the broker operations that result in reduced access to services for members of state programs and timely arrival and drop off are extremely prevalent within the operations of the brokerages. These include access to scheduling services for the members of those programs through call centers, which increasingly have a low staffing problems, given the current state of the job sector, jobs in the United States. We have a 56% cancellation rate happening when rides are distributed to our network of fleets, and a no-show rate that increasingly consists of numbers of 15 to 20% on a daily basis. What these late cancellations and no-shows contribute to are inefficiencies with us being able to route our drivers and to appropriately pick up the members of these programs in a timely manner. Whether they are ASAP requests or pre-booked trips, this all contributes to inefficiencies within our operations. When we receive cancellations from members, we are required for our staff to be able to contact the brokerages to get a cancellation approval, which, as noted in the chat space, can take upwards of 30 minutes. Also, with no-shows, we are made to stay on site until we receive a no-show approval from the brokerage, all without being compensated for our wait time or our driver's wait time. Again, all of these conditions are contributing to late arrivals of our providers to pick up patients needing services and access to the services that are incredibly needed for these members. Thank you.
All right, Stan, you may unmute.
Is it unmuted?
Yes, sir.
Hi, Stan Sipes from Vail. And appreciate all the comments before. We are what we like to call a transportation benefits manager as opposed to the broker. So I would agree with the comment made earlier that the concept of broker is past. And truly what we are holding ourselves accountable to is managing the benefit. So coordination for this topic is really challenging, has always been challenging when really matching demand with supply in the real lives of these members has always been a challenge. And so I'm going to repeat what I said in the first listening session with respect to a way to open up the access to resources is a national set of appropriate credentialing and training standards based on the need of the patient, just as we do in the healthcare industry, that would enable some of what, at least a little bit of alleviation of some of these challenges when the requirements are so heavy on the providers of this, service. So just really encourage that, number one. And I want to speak a little bit to access to one of these resources that's mentioned, and that's paratransit. Paratransit, the source of, for their revenue comes, it's predetermined based on predicted number of rides. And so when we in the NEMT industry are encouraged to utilize that resource for NEMT, it puts pressure on that agency to actually provide trips that they are not being paid for. And so I would encourage CMS to sit down with the transit authority of this country and determine a way to, to better manage and that coordination between, NEMT and access to paratransit services, which are there on the ground in many communities and should be utilized. It's just, I think, both parties have to sit down and agree on the goal and make sure that funding is appropriate. And then last on, as far as encouraging, CMS, rural and tribal land issues, I think I just spoke to, I think one of the ways that we can address the rural issues, and that's by opening up the credentialing appropriately to open up additional resources in rural areas to be able to, provide the service. But on the tribal land side, what we see understandably across the country is the communities and, the Native American communities want to provide transportation for their community members themselves. And very often, regulations and other encumbrances prevent, the ability for us to do that. So we just encourage CMS to provide oversight there. And then my last comment is this industry has changed a lot, and oversight is required. Technology, data tracking, there is so much available today, and I think increased oversight into this industry is definitely required. So I applaud CMS for looking into this, for listening, and thank you for your time.
All right, Mary, you may unmute. Mary? All right, we'll come back to you. Sherman, you may unmute.
My name is Sherman Pines. I am the chairperson for the Integrated Care Initiative of Rhode Island. To go back to the Uber, is that CMS should ask the providers to have a Uber on call, especially when the driver does not show or late, due to the fact that many of the riders have doctor's appointments that they can't miss. If they miss these appointments, they can't get another one for another 2-3 months. Most of your riders are elderly or disabled, and they're afraid when they don't get their doctor's appointments. So when they call and say, hey, my ride is not here, it didn't show, you should always say, hey, we have an Uber on call, and they'll be right there. So I'm hoping that CMS will talk to the brokers to say, hey, this is what we need. Go out, use an Uber to pick these people up. Thank you very much.
All right, Shelley, you may unmute.
Hi, my name is Shelley Richardson. I'm the Executive Director of the Statewide Independent Living Council of Illinois. We've been working diligently across the state to try to repair some of our transportation issues. And we did a survey of our 22 centers for independent living. And the top 4 issues that occurred for all the centers across the state was there was a lack of dependable medical transportation for the managed care organizations. There was a lack of evening and weekend hours. There was a lack of transportation options for rural areas, and there was a lack of the ability to smoothly travel across county lines. And I want to read for you some specific scenarios. Options Center for Independent Living in serving Kankakee and Iroquois County says they are experiencing difficulties related to MCOs using Lyft or Uber drivers, which don't have accessible vehicles, resulting in people with disabilities missing medical appointments. Life Center for Independent Living, which serves Livingston, McLean, Ford, and DeWitt counties, say there is a limited number of medical transportation providers, and sometimes the Medicaid non-emergency medical transportation providers do not show up. McLean constituents experience difficulties in finding transportation to specialists in Chicago, Champaign, and Peoria. This has resulted in postponed surgeries. Livingston constituents experience difficulties in finding transportation to physical therapy and doctor appointments in destinations such as Bloomington. Soyland Access to Independent Living Center, serving Macon, Shelby, Moultrain, Coles, Cumberland, and Clark counties, say it is difficult for constituents to schedule transportation for out-of-town trips. A constituent served by Aetna missed 10 medical and dental appointments because multiple transportation providers either canceled at the last minute or did not show up. A substance abuse counselor from the Heritage Behavioral Center in Decatur contacted our center about 2 senior citizens who are dual eligible, who tried to schedule 2 recurring trips within the city. They contacted First Transit only to learn that any services they provide in Macon County comes from Effingham Taxi in Effingham County, 1.5 hours from Decatur. Effingham Taxi refused to provide the services because they would not be paid enough through the state rate. A constituent who needed cancer care for a doctor in Springfield encountered the same issues. In both situations, a rural public transit system, which is an NEMT provider, was unable to provide transportation due to staffage shortages. And my last example comes from West Central Illinois Center for Independent Living that serves Hancock, McDonough, Shule, Adams, Brown, and Pike counties. There is a limited number of medical transportation providers, and sometimes the providers scheduled through the MCOs do not show up. One constituent in Macomb needed eye surgery in Quincy, scheduled a ride through the MCO on 3 separate occasions, and each time the provider failed to show up without notification, thus canceling the surgery. As you can see, the numbers are, the stories are great, and I just wanted to share those personal stories with you, and thank you for your time.
All right, Mary, if you're there, you may unmute. Mary, if you're there. All right, if not, we'll move on to the next person. Tamira, you may unmute now.
Yes, I serve the Northwest Louisiana area through 5310 DOTD, and we are also a Medicaid managed care contractor. And one thing I want to point out that we are dealing with in our area, and that needs to be looked at when we look at our brokers, is it's not always providers that don't show up. It's also the brokers that don't book with a legit provider. In our area, we have brokers who will book with a provider 3 or 4 parishes away, because that counties in other states, because that provider is a lower rate for them. Well, if that provider doesn't get enough transports to come to our area, they will cancel sometimes an hour beforehand. And that does not give anybody enough time, the broker, nor the client, nor the doctors, enough time to then get them rebooked. So these brokers are trying to just save their dollar in order to help their bottom end profit by not booking with a provider that can actually serve the client in their area. So that's what really needs to be looked at on the bottom line. Thank you.
All right, there seems to be no more questions in the queue.
Thank you, Jay. And thank you all to everyone who has commented so far, and for all the comments in the chat. Do want to keep the floor open. I see we've got one hand raised. We'll keep the floor open for the main topic about coordination topics, brokers, MCO community, paratransit, and see if we get a few more. And after that, we can move through each of the subtopics one at a time. We do encourage you to use this time to make comment on the main topic or any of the subtopics. And Jay, we do have one in the queue.
All right, yes, we do. Dan, you may go ahead and unmute.
Hi, this is Dan Reed again. just want to make a comment on rural issues that have come up, and hopefully this is the right time to do it. Many parts of the geographies covered by Medicaid are rural areas lacking in community transportation resources and certainly lacking in TNC taxi and mass transit. Often these areas are insufficient to support even one, let alone two NEMT providers to operate either at a profit or within the confines of existing available funding resources. CMS should require states with large rural areas to make sure that their RFPs or IFBs require respondents to offer a coherent and realistic rural area strategy for supplying trips. Simply allowing a responder to state that they will have an NEMT provider cover an area is insufficient if the respondent does not both one, recognize and acknowledge the need for different strategies in rural areas versus metro areas, and two, have a developed and realistic plan for implementing such strategies. Beneficiaries living in rural areas are entitled to receive the same quality of services, for example, credentialed and trained drivers and quality vehicles, as all beneficiaries living in higher density population areas. However, that is often not the case because the respondents refuse or fail to implement the necessary processes to ensure an adequate and preferably well above adequate and consistent supply of quality NEMT providers for rural areas. Indications of a realistic and coherent rural area NEMT plan would include attributes such as acknowledging the need to pay for deadhead mileage for an NEMT provider to travel to the rural destination, paying a guaranteed fee for trips in rural areas to compensate NEMT providers for the cost of cancellations at the door or no-shows, paying a higher mileage rate and base rates in rural areas to compensate for the lower trip volume a vehicle might have for the day, and to allow the NEMT provider to still at least cover their fixed costs, labor, insurance, vehicle maintenance, et cetera, which tend not to vary between low area, rural, and high volume metro areas. Paying wait time for NEMT providers, since often in rural areas, they can't send their driver off to do another trip and would be required to wait on the beneficiary to complete their appointment. And the ability to identify and track separately performance metrics in rural areas so that the real ability to service a rural area can be measured. For example, a broker with an insufficient or unincentivized NEMT provider network in a rural area may have very poor on-time performance and a high percentage of unfulfilled trips. But if those poor metrics from a low volume area are just simply mixed in with better metrics from high trip volume areas, it would be easy to retain higher metrics, but not really reporting what's going on in the rural area. A failure to have a good rural area NEMT service in any response should be a red flag and possible consideration for excluding from a bid for consideration in areas with high rural area geographies. Again, thank you for your time.
All right, Michelle, you may unmute.
Thank you very much. Dan, I think it is who was just speaking. You really hit on some issues. I'm with Rockbridge Area Transportation System in Lexington, Virginia. We are very rural on the very western side of the state. And our organization is a 501c3 nonprofit NEMT in our area. We have a team right now of 12 fully credentialed pass certified drivers. We are frequently with the insurance carriers with whom we are credentialed, frequently having to explain the challenges as a small nonprofit in the rural area, challenges with deadhead, where we are expected to drive maybe 12 to 15 miles to pick up a rider whose medical appointment is 2 to 3 miles from their home. We get to their home to pick them up, they're a no-show or a late cancellation for a 6 a.m. pickup. We don't get paid basically for that time that it takes for us to drive that distance to pick them up for a short distance, and or we pick them up for the 2 to 3 mile drive to their appointment, but we don't get paid for the deadhead to go pick them up the many miles out. We have one person who's a 45-minute drive at the very end of a very windy dirt road, who we have to pick up at 3:45 in the morning, 3 days a week for dialysis. So it's easy to assume, oh, that's easy to do, when actually it really is not. Our reimbursement rates, yes, we were told by one of our larger insurance carriers, well, you're rural, so we're not going to pay you guys as much. You don't need as much. I said, well, that doesn't make sense. If you're in the city and you're transporting 5 people to the same place at the same rate, you're making 5 times the actual cost in theory, compared to we have to pick up one person and drive them 5 to 10 times farther in distance and expected to accept a lower rate in compensation to do that does not make any sense. We are in the course of adjusting our performance measures, and it goes to not only holding our organization, both as a service provider and a nonprofit, financially accountable to ensure that we are improving our performance and providing the best performance possible, but also that the insurance carriers who are working with us are held to the same standards too. So we may be small, but we are mighty. We also want to work with other transportation providers because our ultimate goal is to help the community and advocate for the people, not just the profit. Thank you.
Thank you. It looks like we don't have further callers in the queue. Why don't we keep the floor open for any additional comments on rural issues? And then we can go to other topics. Looks like we have at least 2 in the queue. Again, looking for comments on rural topics, and then we can move to the other subtopics as time allows.
All right. Tammy, you may go ahead and unmute.
Yes, this is Tammy Mim with the TennCare Transportation Program in Tennessee. One of the things that I believe that would make a difference is to identify ways to relieve burdens of NEMT providers. For example, the non-payment of no-shows. Also, the administrative burdens of NEMT providers, such as credentialing that is currently being reviewed by ProCredX and NEMTAC. By paying for no-shows, providers will be more willing to accept those trips considered at risk of a no-show, which results in non-payment. The standardization of expectations and requirements that would allow at a state level an easier oversight and without putting the providers out of business. The cost of sanctions related to not meeting those standards during one trip could honestly be detrimental to a small provider. Thank you.
All right. Gail, you may unmute.
Hello, my name is Gail Nels, and I'm here in Colorado. And I've worked with transportation and the non-emergent medical transportation benefit for many years. What we're seeing in the rural is sometimes we have to drive 70 miles out of a rural setting in Colorado into the Denver area for specialty transportation. I think you're pretty aware of the problems in the descriptions that have gone before me. But what I've seen is we help break up, I want to say, the NEMT statewide brokerage. And we're looking at a more regional model. We think that is the one that works best, is these transportation providers. We understand our communities better and what it actually takes from a time period to get people and to pick them up. And we're more familiar with the types of rides that will no-show. What we're seeing is dialysis patients do not cancel or no-show, yet our behavioral health NEMT rides have a significantly higher percentage. And so we would like to some kind of acknowledgement of this different kind of treatments. And although we work closely with the Medicaid behavioral health provider about their trips and their schedules, we are still burdened with that no-show and the cost of that. I'd really like to see a greater coordination between CDOT and the Department of Transportation and the braiding of the funds. I know that there is the CCAM organization, the Coordinating Council on Access and Mobility, and working with Danielle Nelson at the Department of Transportation to help us braid these funds and coordinate, especially in these rural areas, with the public transit providers and the other human service providers, as we use FTA 5310 funds and 5311 funds, and then work with your NEMT Medicaid funds to help provide that transportation. So I guess I'm asking for greater coordination between CMS and DOT.
Great. Any other one last call for comments specific to rural issues? Okay, oh, we have one. Well, it disappeared. So a call for rural issues. If none, let's move on to tribal land issues. Any comments? Commenters would like to offer their thoughts on ways we can improve NEMT issues on tribal lands. Okay, let's move on to coverage of transportation to services not provided by Medicaid. And Jay, it looks like we have one hand raised.
All right, Kurt, you may speak. Let me go ahead and unmute.
Thank you. My name is Kirk Foster. I used to own a large NEMT company in Oregon that I recently divested myself of. Regarding the payments, this addresses the rural, which I tried to raise my hand for, and I apologize that I failed to do so, and tribal land issues, I think, specifically regarding to cost structures. It is far too expensive for a provider to simply stage vehicles in a rural area, hoping that a ride will come in. It's even more expensive for that provider to commit to providing a ride in a rural area, to send the vehicle all the way out to the rural area with the driver on the clock the entire time, and then have the ride cancel, or the doctor's office need to change the times. This is why you have a huge problem with coverage in rural areas. There simply is not enough money in the pay for completed miles model to sustain a provider operating in those areas. The only way, and I think this applies in tribal areas as well, the only way this will be addressed is if there's a compensation model that includes compensating providers for their availability to provide a ride, as well as for their having provided that ride. And until that model is adjusted to pay for that availability, there will always be a shortage of rides. Every grievance I've heard on this call for if a doctor's office is running late and the provider doesn't wait around for the client, the provider can't afford to wait around for the client under the current structure. I fervently believe that in all areas, until CMS or somebody develops a pay model that pays the drivers to be available to complete a trip, we will continue to have the same failures regardless of any other changes that are made. The underlying problem is that providers are not paid for their availability. They're only paid for completed trips and are expected to absorb any losses related to a ride failure, whether it's their fault or not. Thank you.
All right, Kari, you may unmute. Kari, if you're there, you may unmute.
Good afternoon. My name is Carrie DeWangyatua. I'm a supervisor for a NEMT that provides NEMT services here in Arizona on the Hopi Reservation. So I kind of wanted to speak about the tribal land issues. We do provide NEMT service to our tribal community here. And what we manage as far as providing services for these individuals, don't specifically that they providing services to get bird. We do provide this to our community members in charge. But they do have build their
All right, it seems Kari may have dropped out there due to internet. If she joins back in, we'll go ahead and let her talk again. Gail, you may go ahead and unmute.
I wanted to talk about the services not provided by Medicaid. During the pandemic, we were able to access kind of COVID funds to support transportation in the rural areas as we took people to medical appointments under the NEMT. But then for also them to get their prescriptions made, we were accessing some of those COVID funds for that kind of help augment reimbursement for those transportations. And that was a great benefit to us as a transportation provider. We also were able and continued to braid the funds with from a social determinants of health with the Older American Act dollars under CMS. It helps support older Americans that are 60 and above for transportation. So I'm saying that, so we're trying to get creative, but maybe not all providers in rural communities are participating in those programs or have access to the programs that are set up like that. So I would suggest that as a result of this listening session, that perhaps there's more modeling about what works around these, I will say, complicated systems of rating different federal funds to provide transportation.
All right,
Thank
it
you. And
seems
again, I think it looks like the queue is empty, Jay. Maybe we should move on to any further comments on access to services, timely arrival, and drop off? Or if anybody has any comments on any of the topics or subtopics that we've covered today, the floor is open.
all right. Seems we have a question here. Anna Hall. You may go ahead and unmute.
Hi, sorry if this was brought up already. I got to this a little late, but I'm in Indiana, and around here we have a hard time crossing county lines because of the distance, because of the reimbursement, because of timing, wait time, all that kind of stuff. We just and our rural counties, we have we're kind of isolated up in the corner of Indiana, Fort Wayne. And so all around us is rural counties. And there is a huge issue with access to major medical things because of the, the distance, the reimbursement, the wait time, all those things. Thank you.
All right. Tammy, you may unmute.
Yes, this is Tammy Mimm from Tennessee again. One of the things that I have noticed when you talk about providing services that aren't covered by Medicaid and the network that is used to service NEMT trips for Medicaid is used for those same purposes, is it puts a challenge and a strain on the NEMT network that is being provided by our contracted NEMT brokers and providers. When they're already in a point of struggling to secure providers and there is this other need, and I am in full support that is something that is definitely needed. I just think it has to be done in a way that supports or allows the increase in network, either by funding or requirements, ease of requirements, or something like that. Thank you.
Great, thank you very much. Still, the floor remains open. If anyone would like to offer further comment, do want to remind any speakers today that do have prepared comments that they worked from. If they would like to submit those to the mailbox, NEMT engagement@miter.org, and my colleagues will put that in the chat. We would appreciate it if you would forward your written comments to us as well. And for anybody today that thinks of other comments that they would like to have made after the session, once it's submitted to that email box, we would appreciate that as well. The floor is still open. We're going to keep the floor open, and the chat has been active. For any comments related to today's topics, we would greatly appreciate it. And Jay, I see we have a couple, so I'll turn it back to you.
All right. Wesley, you may go ahead and unmute. Wesley, you may go ahead and unmute. All right, we'll come back to you. Andrea, if you're there, you may unmute.
Good afternoon. The issues that seem to be coming up are how to, and this is one of the things that we would love CMS guidance on, is how to bridge the fact that NEMT has been identified as a high area for potential fraud, and the dictates of what we can and can't pay for because of that potential fraud, with the balance of motivating and making available transportation providers at a rate that they can afford to operate at, when there are so many issues such as no-shows, long wait times, will call, and insufficient provider networks within the rural areas, and insufficient transportation networks and availability within the rural areas.
All right. Alex, you may go ahead and unmute.
Good afternoon, everyone. I'm giving you a call, or I just wanted to say a little bit from my perspective. This is from, I work within a hospital and with our outpatient services. And one of the issues that I see that come up, and I think that this would be something that either CMS or someone could give guidance to, and maybe trickle down for some assistance with our local agency. If someone's so close to a bus route or some other service, they get denied. But I think there would also be good help if they could still be provided with like bus passes in those situations. Or I think the other big thing that comes up that I think ends up being a lacking there also is education on how to use the bus stop, how the bus schedules work, kind of working with a patient about which are the best times for them based on their area and based on when the bus gets to their providers, with being able to help them that way. Because if the insurances are going to pay out for EMT services, if they lived somewhere else, there would be the hope that there would also be help for them, even if they are near a bus, and it would be more affordable than the broker themselves or someone else. Thank you for your time.
All right, Jonathan, you may unmute.
Hello, Jonathan Anthon from ISI Technology, the makers of Route Genie. I apologize, I'm a little late. I wanted to talk about coverage of transportation services that are not provided by Medicaid. We're starting to see a little bit of a movement, especially in ACOs, accountable care organizations, and even some MCOs, where transportation services outside of just medical transportation are being offered, because at the end of the day, I mean, the ROI that has been proven for NEMT time and time again is transportation is a major factor and a social determinant of overall health. But there are other social determinants of overall health, including things like access to healthy foods or activity levels. So we hope to continue to see that trend, and hope that CMS may start to look at that as well, as potentially providing transportation services that contribute to improvements in other social determinants of health besides access to reliable medical care. Thank you.
All right. Anna, you may unmute.
One thing related to NEMT that we run into is we'll get to somebody's house. Sorry about that. We'll get to somebody's house and they don't have a ramp and they have stairs. So I don't know, around here, we have to rely on a nonprofit organization or a family member to build the ramps for folks. So it would be helpful if Medicaid would also provide the ramp so the person can get out of their home to even get the transportation to medical care.
Thank you again to all of the commenters. We'll keep the phone lines open for a few more minutes and see if there's any further commenters from the group that we have online today. Again, greatly appreciate it. And again, a reminder that if you have prepared comments, please email them as well as stating them on the call or in the chat to nemtengagement@miter.org.
All right, it seems we have one hand raised. Tom, you may go ahead and unmute.
Yes, this is more of a general question. It's not specific to today's session, but we hear about these sessions being recorded and we can go back and review them. And I haven't been able to find a successful link to any of that. And I asked in the chat and I was told they'll be provided at a later date. Do we have any idea how we can go back and review some of the previous sessions? I have a specific interest in maybe even an attendee list. Somebody brought up something I wanted to kind of have an off, outside of the meeting because it wasn't really related, have a topic exchange with, but I have no way of figuring out how to get back in touch with that person.
Yeah, thank you for the question. At this point, we don't have any specifics on the availability of the information online, but we will certainly update that when we have information and make sure that we push that out to everybody that has attended the calls.
Thank you.
Any other comments for today? So hearing none, I'm going to begin to close out the session. If anybody has comments that they think of during the time while I'm closing it out, please raise your hand and we will still call on you. We do have the time blocked until the bottom of the hour. So this brings us to the conclusion, or almost the conclusion, of today's session. As a reminder, today's session was recorded for note-taking purposes. If you have any additional comments that you were unable to share today, please feel free to email them to nemtengagement@miter.org. We also, again, encourage you, if you have other comments you didn't mention today, comments you think of later, or comments that you had prepared, please email them to nemtengagement@miter.org. We really appreciate you joining us for the fourth of our scheduled NEMT listening sessions. It's actually, we had one rescheduled, so this is actually technically the third. We do have one remaining session to be held. That's listening session was rescheduled from last week. It is now going to be held on April the 28th. That session includes economic factors and cost containment challenges in NEMT. And that will be the fourth and final of this series that we are hosting on NEMT listening sessions. If this topic is of interest to you or your organization, please go to medicaid.gov to register. The direct link is listed on the slide on your screen. We'll also drop a link that you could directly click on to register, and that link will be in the chat. Thank you again for joining us today and for helping CMS to identify and address the ongoing challenges associated with NEMT. Again, it is 3:17 on the East Coast, and we have a few minutes left. So we will hold on the line if anybody chooses to raise their hand for at least a few more minutes. And the chat is still open if folks want to use the chat feature, but we thank you. And we look forward, we thank you for any this or past participation. And we look forward to hearing from you again if you choose to join us on the 28th. Thank you. Thanks, everybody that's hung on for these few minutes. We're going to go ahead and close today's call. Thank you again for participating. Your comments are greatly appreciated, and we look forward to everyone's participation in our final call on the 28th. Have a great day. Thank you.